Invitation. And yeah, for the next 45 minutes, I think I'll tell you the story about how we started to think about the potential role of acetaminophen and how it might affect the developing lung, and then talk about the work we still have to do. I don't have any disclosures. And, this study came about as I worked on the editorial board of various journals. And starting in 2014, I was asked to write editorials and commentaries on the growing use of acetaminophen or paracetamol to close the patent ductus arteriosus. And most of these commentaries that I wrote were relatively positive. But then by 2018, 2019, it dawned on me that during my clinical fellowship, so I was a fellow at Children's Hospital Philadelphia between 2005 and 2009, I hadn't written for acetaminophen a single time. And then all of a sudden, by 2018, 2019, almost every single baby in our unit had paracetamol on their MAR, their medical administration record. And I really thought, well, that was a quick uptake in the use of a medication. And I really thought I should educate myself on the studies that were done to prove that it was safe, especially in the setting of a developing lung. And that journey has taken me down this path. So the overview of the talk, I'm going to talk about why perinatal acetaminophen exposures are increasing, talk about the mechanisms underlying acetaminophen toxicity, and I'll use acetaminophen, paracetamol, and APAP interchangeably. APAP is the short form of the chemical name. I'll review the data supporting the hypothesis that the lung is susceptible to the toxic effects of acetaminophen, and then talk a little bit about the preclinical data that we're generating in the lab to show that acetaminophen-induced pulmonary injury is something we should be thinking about. So in a word, perinatal acetaminophen exposures are ubiquitous. And perhaps the place where it happens the most is during pregnancy. There are not many, there are very few analgesics that are quote unquote safe to use during pregnancy. Over 60% of pregnancies in the US have an acetaminophen exposures. These numbers are pretty consistent actually across Western Europe and Australia as well. And really, it was with the opioid epidemic in the United States that paracetamol or acetaminophen entered our unit. And really, the charge here was to decrease opiate exposures by incorporating acetaminophen into a postoperative pain protocol. And there were a number of really good randomized controlled trials, primarily using term infants undergoing surgery. I'm just pointing out one here that was published in JAMA that showed that, yes, if you incorporate the use of acetaminophen, you could reduce the opiate burden. And being clinicians, we know how this works. If you've got a baby in your unit, you've got acetaminophen postoperatively for a pyloric stenosis repair, and then next door you have a 25-weeker who's 2 weeks old and maybe looks to be in distress, you might just try the medication next door. And it was with this, slide of medication use that the first observation or case series showing that acetaminophen could close a duct was published. So a group in Israel published this case series in 2011, and I'll just show you what they wrote. So initially, paracetamol over-counter was given for unrelated reasons to a 26-week gestational age infant who had a long-standing, persistent, hemodynamically significant duct. And after getting acetaminophen, this closed. And then they go on to describe a handful of babies where they made this observation. And so literally overnight, we have a drug used to treat a condition that vexes many neonatologists. And I think it's important to remember, and this is a quote just taken from a review, that says the most commonly used dosing regimen to treat PDA, the 15 milligrams per kilo Q6 for 12 doses, is twice as high as the previously recommended maximum dose in preterm infants and was adopted without dose-ranging studies to establish safety and efficacy. And this is true. So if we go back to the randomized control trials, looking at the use of this drug in term infants, there were pharmacokinetic and pharmacodynamic studies. There were very, very few infants, less than 28 weeks, that were included in these studies. So we literally chose this dose with no real knowledge about what we were doing. So what has this done? And I'll just, for the treatment of the PDA, and I'll just show you some data published just at the tail end of last year. And we're looking at babies in the Neonatal Research Network. So this is a handful of centers geographically distributed across the U.S., funded by the NICHD, that contribute data. And you can pull data and look at practices. So we're looking at 2012 to 2021, the total number of babies included in this registry, so relatively stable between 1,100 and 1,400. The percent treated for the PDA is relatively constant at about a quarter. And if you look at the percentage treated with acetaminofén before 2015 or before 2016, it's 0. By 2016, it's the first time it hits the database. And by 2021, it's over 50% of the babies. And if you look at the drug rank, by 2021, it is the #1 most commonly used drug to treat PDA in babies that are at NRN centers. And there have been studies that show this same trend is present in Europe, Turkey, and in parts of the Middle East. And so why is this? And I think this quote summarizes it best. It's the clinical evidence shows a low or absent hepatotoxicity in neonates, suggesting the existence of a large therapeutic serum concentration range for paracetamol. And so I think that sums it up pretty well, that, this is a drug we can get over the counter. We associate it with liver toxicity. That hasn't been reported, so it must be safe. And actually, I pulled this study because it might be relevant to you. So this is a survey of neonatologists in New Zealand and Australia, published back in 2019, asking if you used acetaminofén or paracetamol to close the PDA. And so at that time, so again, this is 2019, 70% of the respondents said, yes, we have used this to close the PDA. And then I was interested to see, of those that didn't use it, why weren't they using it? So asking the question, why don't you use it? Most of the respondents indicated, wow, we prefer using NSAIDs, or we have a lack of evidence to show that it works. Very, very few were concerned about the safety of the use of acetaminofén in this patient population. And I think if you ask anybody, this is true. There's very little concern about any potential toxicities with this drug. And then there's that quote again. All right, so we're using it, but is it safe? And this is a key point of the talk, and something I want you to take away is that acetaminofén or paracetamol toxicity has to do with cell-specific expression of the enzyme that converts acetaminofén to a toxic metabolite. And that enzyme is CYP2E1. So typically with an acetaminofén exposure, that drug undergoes glucuronidation or sulfation. That creates non-toxic metabolites that are readily excreted. When those pathways are either absent or saturated, there's a third metabolizing pathway, that is the monooxygenase CYP2E1. That converts acetaminofén into NAPQI, which is a highly reactive toxin. This is rapidly detoxified with glutathione. That's why we give N-acetylcysteine to those who have taken an overdose and arrive in our emergency room. But with consumption of glutathione, NAPQI accumulates. It preferentially targets complexes of the mitochondrial electron transport chain. You get mitochondrial toxicity and cell death. And so why do we think about liver toxicity? Well, in the mature, and I have to stress mature liver, CYP2E1 is expressed specifically in the hepatocytes that surround the central vein. Demonstrated here by this beautiful immunohistochemical image showing the brown staining of CYP2E1 around that central vein and very little staining around the portal triad. So it's no surprise if cell types specific expression of this enzyme drives toxicity. If you give an animal an overdose of acetaminophen, you get a histopathological picture that looks like this. So you see the cells around the central vein labeled there with CV are pale, they're dead. You have dilation and pooling of erythrocytes in the sinusoids, but the hepatocyte around the portal triad is completely fine. And to me, this is just a fascinating picture. You can have a hepatocyte that doesn't express CYP2E1 that is completely fine. Right next to it, that cell expresses CYP2E1 and it is dead. And why we don't see hepatic toxicity in the neonatal period is that CYP2E1 in the liver is developmentally regulated. The expression of CYP2E1 is developmentally regulated. And you don't see adult levels in the liver until about 3 months of age, as demonstrated by this graph that was published, over 20 years ago. So what we see moving left to right is in the second, third trimester, or premature babies, essentially when they're born, and in the first month of life, hepatic CYP2E1 expression is low, and then it gradually increases with liver maturation. So this would predict that the liver is not a good place to look for toxicity related to acetaminophen exposure. And this goes along with our observations. So, we don't typically see it. And then you can see case reports like this. So this is lack of toxicity after paracetamol overdose in an extremely preterm infant. This is a 12-day-old ex-25-week baby given 450 milligrams per kilo IV. That would be enough to kill me in about 4 hours. This baby had no increase in liver enzymes, bilirubin, or prothrombin time. If you're not expressing CYP2E1, you will not have liver toxicity. And you can see that again in the literature. And you can actually replicate this using preclinical models. And I'll just walk you through this chart. So here they're using mice, and we have the age on the left side. We have baseline hepatic glutathione levels compared to adult. Glutathione depletion at 2 hours after a hepatotoxic exposure. So that if you have glutathione consumption, that means you've generated NAPQI and you're detoxifying it. Then you have the percentage of animals or the percent of hepatocyte necrosis around the central vein. And then you have number of surviving animals. So here are the data for a 35-day-old animal. That's a relatively mature mouse. Your baseline hepatic glutathione level is 100%. You have 85% depletion at 2 hours because those animals express CYP2E1 in the liver. 100% of them have hepatocyte necrosis, and none of the animals survive. With a 10-day-old mouse, they're glutathione replete. They have less depletion of glutathione because they have less NAPQI production, less hepatocyte necrosis, and more survival. And by the time you get to 3 days, even though they don't have as much glutathione, so they don't have as much as the detoxifying enzyme as adult, they have even less depletion because they're not generating the toxic metabolite, very little necrosis, and all the animals survive. So this is something, this hepatic resistance to acetaminophen toxicity is something you can demonstrate in a preclinical model, and it's something we see again clinically. So to summarize that first part of the talk, the preclinical data predict accurately that hepatic toxicity is not a reasonable measure of acetaminophen safety, and that is due to the hepatic developmental expression profile of CYP2E1. Are other organs susceptible to the toxic effects of acetaminophen due to CYP2E1 expression? And if so, is CYP2E1 expression developmentally regulated similar to the liver, creating windows of susceptibility? And if we're not asking these questions while we're using this medication, in my opinion, irresponsibly. So preclinical studies trying to figure out how acetaminophen caused toxicity were performed in the late 70s and through the 80s. And if you go back and you dig through the literature, you can find that the lung is very susceptible to acetaminophen toxicity. So this is published in 1989. They took adult mice, they fast them. And the reason you fast a mouse before exposing them to acetaminophen is to hopefully standardize glutathione levels in the livers across the animals. They're given a hepatotoxic dose of acetaminophen, and then they just looked histologically for injury. And here you can see they graded it from 0 to 4+ necrosis. And they look at the liver with acetaminophen. There's a bell curve. There's some biologic variability, but most of the animals have 2+ or greater. 57% showing this degree of injury. When you look at the lung, there's actually a tighter bell curve in the amount of animals demonstrating necrosis graded higher than 2+ is actually higher at 85.7%. And you can find a handful of papers showing this association, and why interest was kind of lost in this observation, I'm not sure, but people clearly followed hepatic toxicity, but this was kind of buried in the literature. So why is the lung susceptible? Well, you can imagine if CYP2E1 is a xenobiotic enzyme that's responsible for detoxifying substances, that you might express this enzyme in your lung. And this is a nice immunohistochemical image showing CYP2E1 expression in the club cell there. This is mouse lung. And then since that time, people have demonstrated that CYP2E1, again, the enzyme that's responsible for creating the toxic metabolite, is expressed in whole lung tissue, bronchoalveolar macrophages, and lymphocytes. So it's kind of expressed throughout the mature lung. So it's pretty accepted preclinically that the mature lung is sensitive to these doses of acetaminophen. And knowing that, and with all this new perinatal use, surely we have reported these pulmonary outcomes. And I think this is actually not true, and it's something that we need to think about. But if you dig through the literature, you can find a couple signals that demonstrate, we should have a little concern. So thinking about prenatal exposures, and I'll just point you to this meta-analysis that was published in 2017. So there are now more than 1.5 million pregnancies looking at prenatal ingestion with acetaminophen in childhood respiratory outcomes. And the odds ratio for reporting a poor childhood respiratory outcome is 1.19. So again, this is more than 100 or more than 1 million pregnancies in these databases now. But this association between exposure and poor childhood respiratory outcome, which is typically classified as asthma, has been widely debated. And that's because when you look at subsets of these patients, there's no consistent association with what we tend to associate with asthma. And that's IgE levels, hay fever, skin tests, eczema, or allergic rhinitis. So suffice it to say, this is debated. However, there are limitations with these large databases. If anybody has worked with these, you know that a lot of, when you've put 100,000 patients into this database, asthma often comes from ICD-9 code because somebody got a prescription for albuterol. But many of these patients are not receiving pulmonary function testing or a formal diagnosis of asthma. So we don't know if it's asthma or some other lung developmental problem. Okay, so how about our NICU exposures? And I just want to put the disclaimer here that prior to the last 5 or 6 years, acetaminophen exposures in preterm neonates have never occurred. And if we're not anticipating an adverse event, it's not going to be reported. Now, most of the trials looking at acetaminophen for PDA have reported BPD as an outcome. This is reported as a marker of potential benefit of ductal closure. It's not because anybody thinks that acetaminophen is causing BPD. So I would say BPD is potentially a very poor marker of acetaminophen-induced lung injury, but if there's any potential signal for increased BPD, that would support equipoise and further study. All right. So there's a Cochrane review published in 2022 that looked at 2,278 subjects. The conclusion was that acetaminophen works as well as ibuprofen to close the PDA with no difference in BPD. But before we just accept that conclusion, I'd like us to take a close look at these studies. And there are a couple different designs on the randomized controlled trials included in this Cochrane review. So there's like acetaminophen versus indomethacin, acetaminophen versus ibuprofen IV. But here I'm just going to take it to acetaminophen versus ibuprofen straight up. So there were 8 studies, and in total, 400 babies randomized to acetaminophen, 400 randomized to ibuprofen. And when you look at the rates of BPD in those arms, they're essentially the same, about 10 or 11%. But I would pause and have you ask yourself, when was the last time I treated a baby for PDA who had a 10% risk of BPD? Usually no. And this indicates that the patients that have been reported are not really reflective of the babies that at least I am treating, and my guess is you would potentially be treating in your unit. If your rate of BPD is about 10%, you're probably treating a much more mature patient population. And sure enough, if you look at the 400 babies randomized to acetaminophen and reported in the Cochrane review, and you look at the mean gestational age of those babies, only one study, the Onsel study published in 2014, had a mean gestational age of less than 28 weeks, and that was only 27.3. And if you dig through the data and look at how many babies were actually less than 28 weeks, it's only about 70. So there's been if you think back to that NRN data I showed where acetaminophen is the #1 drug used to close the PDA, we're making the conclusion, or we've drawn the conclusion, that this is safe based on less than 70 babies being randomized to treatment. And to me, that's kind of a scary thing. So with that in mind, I worked with a friend of mine from training, Eric Jensen, and looked at all the babies in the NRN that had been exposed to acetaminophen for treatment of the PDA. And there are a lot of limitations with this study. We didn't look at, co-treatment with acetaminophen for pain control. We don't have dosing information, but we wanted to leverage the number of babies in this data set to look and see if we could tease out any markers of poor respiratory outcomes that were not as significant as BPD. So we looked at babies 22 to 28 week gestation, or 400 to 1,000 grams, born between 2016 and 2020, that received drugs for PDA, and that was either ibuprofen or APAP, ibuprofen, or indomethacin. And then we used death or grade 2 BPD as our primary outcome, but really we did this study to look at all the different respiratory outcomes that are included in this NRN database. So here's the flow chart. It's not really important to go through, but at the end of the day, we had 627 babies that got acetaminophen and 1,294 babies that got COX inhibitor only. And, to me, I'm happy with this work because it is the largest data set looking at tiny babies, so a gestational age of about 25 and a half weeks that got acetaminophen only for PDA, or COX only for PDA. Here, again, is just data to demonstrate the rapidly growing use of acetaminophen. So in the dark blue bars is the number of infants treated with acetaminophen, moving left to right from 2016 to 2020. These are single drug treatments alone. And then if you add, if you got acetaminophen and ibuprofen, dual course, there are the numbers. And you can see by 2020, acetaminophen exceeds the use of both ibuprofen and indomethacin. So to me, this just indicates that we are willing to give acetaminophen to our smallest and our sickest babies in the absence of any real data demonstrating that it's safe. When we looked at the outcomes, death or grade 2 BPD, there was absolutely no difference between acetaminophen and COX inhibitor. When you separated those outcomes, death before 36 weeks or grade 2, grade 3 BPD, absolutely no difference between those two. But really, I was interested in these maybe, these more subtle indicators of potential lung injury. So HOMO2 prior to adjustment was significant. So going home on oxygen was significantly higher in the babies who received acetaminophen. Home respiratory medication use trended higher, but it was not statistically significant. And then actually before adjustment, death before discharge was significantly higher in the acetaminophen group. And then with Eric's help, we did a bunch of adjustment. And again, I view this as not definitive, but hypothesis generating. And I hope people just start thinking about it. So we adjusted with various models. So model 1 was looking at perinatal factors. Model 2 was perinatal and early postnatal. And model 3 was perinatal, early postnatal, and late postnatal. So we just did a lot of different things. And you can see what factors these were in the original paper. But when we looked at death before DC or home O2 unadjusted, that was statistically significant with an odds ratio of 1.28. That significance went away when we adjusted. When we looked at death before DC or home respiratory medication use, that actually became significant with some of the adjustments. And then when we looked at death before DC, that was significant with some of the adjustments and not with the others. As someone interested in lung injury, I was interested in those respiratory outcomes. Eric became very interested in that mortality signal. And the reason he did that, just focus on that number 1.28, and it's here. If you go to the Cochrane and you looked at the subgroup analysis, so if they reported babies less than 32 weeks, paracetamol, oral IV versus ibuprofen, all-cause mortality during the stay. You can see that point estimate of 1.28 is almost exactly what we saw. Now, they only had about 190 babies in each group, and again, we had 600 and 1,200. So, certainly not a signal demonstrating that this is safe, and potentially actually a signal that this could be quite harmful. Okay, so is exposing the premature infant to acetaminofén safe? So my assessment is that the clinical data demonstrating safety are lacking at best and very concerning at worst. And, as a basic scientist, the charge is on me to ask, why would the developing lung specifically be susceptible to acetaminophen toxicity? And if I don't consider that we may be exposing vulnerable babies during specific developmental windows to unanticipated harms. And again, I'll draw your attention to this, the developmental expression profile of CYP2E1 in the human liver. So if we know, one organ has a developmental expression profile, it's reasonable to hypothesize that there might be developmental differences in CYP2E1 expression in the developing lung. Now, luckily, we have access to publicly available whole lung RNA-seq from the developing murine lung. So this is data that was funded by the NIH and then NHLBI. And they're looking at, so they take in whole lungs from mice at embryonic day 16, moving left to right, 18. They're born at about E19, and then they took lungs from a mouse that was half a day old, 1 day old, and then all the way up to 28 days. And this is the expression profile of CYP2E1. And what you see is that CYP2E1 is highly expressed in the murine lung right before delivery. Then it falls, and that the mouse is in the saccular stage of lung development at that stage. It stays in the saccular stage until about postnatal day 3-4. Then it enters the alveolar stage around 4 or 5, and then you get this secondary alveolar bloom that's dependent on contraction of secondary crest myofibroblasts at about P14. And so we see another peak expression of CYP2E1 at P14. And so this really got us quite interested because it's very unusual for a specific enzyme to be expressed in a developmental pattern like this. We further queried this database and another database that's available from Vanderbilt from the lab of Jen Sucre and looked at, is it just a lot of different cells in the lung expressing this CYP2E1, or is it a specific cell? And so this is single cell. So now they've, minced up the mouse lung, isolated specific cells, look at RNA expression, and what you can see, so size of the dot is the percentage of cells expressing CYP2E1, and the darkness of the blue is the average expression. And you can see expression of CYP2E1 in the developing murine lung is most found in this myofibroblast. at E18, so consistent with this peak here, and again at P14 over here. And why is this important? This is important because this mesenchymal myofibroblast, the one that is expressing CYP2E1, is identified by its expression of platelet-derived growth factor alpha, or receptor alpha. So this cell expresses that receptor. The ligand for this receptor is platelet-derived growth factor. We know from years of looking at lung development, there are developmental implications when you disrupt this signaling cascade. So you can either disrupt expression of the agonist by knocking it out of the whole animal, or knocking it out of specifically the surfactant protein C expressing cells, or the type 2 epithelial cells. You can also disrupt the mesenchymal myofibroblast's ability to respond to this ligand by knocking out the receptor, or specifically knocking out that receptor in cells in the developing lung. And the phenotype of those animals is as follows. If you take out the agonist, you get an emphysematous-like lung phenotype that was published way back in 1996 in Cell. You get abnormal elastin deposition. If you knock the agonist specifically out of the type 2 epithelial cell, you get emphysema and abnormal lung function. Now, if you take the receptor out of the entire animal, that is embryonic lethal. But if you take it specifically out of the lung, you get an emphysematous-like lung phenotype. So it kind of drives this hypothesis: if you get injury to these specific cells, and again, these are the cells that are expressing CYP2E1, you might have abnormal lung development. And just to take a look at what these lungs look like when you take away these mesenchymal myofibroblasts, we have control animals on the left, H&E staining on the top left. So you have a beautiful alveolar structure, a lot of surface area for gas exchange. Lower left shows normal elastin deposition. When you take away the mesenchymal myofibroblast's ability to respond, you get this emphysematous-like lung structure and abnormal elastin deposition. Okay, so back to the developmental expression profile. We have a peak at E18.5, which is right before the saccular stage, and then you have another peak at P14, which is this late alveolar stage. We wanted to confirm this, so we did RNA scope. So essentially, this is like immunohistochemistry for RNA. At E15, this is the canalicular stage of lung development. CYP2E1 expression is there in red, very little. By the time you're at E19, you see these cells dotted throughout the mesenchyme expressing CYP2E1. When you go out to P14, CYP2E1 expression is here in blue, and you see it nicely distributed throughout the developing lung. All right, so then we used a tool with the help of my friend David McCulley, who's a neonatologist, lung developmental biologist at UCSD, and we used this PDGFR alpha GFP reporter mouse. So every mesenchymal myofibroblast there in the P14 lung is lighting up green. You're able to flow sort those based on the presence of GFP. So you just mince the lung up, get a single cell suspension, identify the GFP positive cells, and then you can check those cells for RNA expression. And when we look at whole lung expression at P14 or postnatal day 14 in the mouse, you look at CYP2E1 expression in the whole lung, it's certainly there. If you compare that to just the GFP positive cells or the mesenchymal myofibroblasts, that expression is enriched. And if you look at expression in the GFP negative cells, that expression is difficult to detect. So it's kind of back to this idea, we accept when the liver expresses CYP2E1 in those cells around the central vein, and you're exposed to acetaminofén at a high dose, you get this type of injury. So, what is happening to the developing lung when each one of those green cells expresses the same enzyme that is killing those hepatocytes? So we're looking at, do toxic APAP exposures injure the developing lung? And I should be careful when I say toxic because, what is toxic to an adult animal is not necessarily toxic to the developing mouse. So here we've taken P14 C57 black mice, we've given them a single dose of acetaminofén, and we give it intraperitoneally. That is delivered directly to the liver. It is absorbed by the peritoneal vessels, enters the portal system, and is delivered the same way an oral administration would be delivered to the liver. We give 140 milligrams per kilo. We assess both the liver and the lung at 6 and 24 hours. This is what the liver looks like in these animals after acetaminofén. So on the left, we have PBS, or essentially saline-treated controls. You can see there's no injury around the central vein. Acetaminofén at 6 and 24 hours, there's absolutely no evidence of injury in these livers. And then we took it to the lung. So here is a control lung, and that's a conducting airway, a terminal bronchial with the pseudostratified columnar epithelium. It's intact. It looks beautiful. This is after 6 hours of a dose of acetaminofén that doesn't injure the liver. So you see those cells that are dying, sloughing off the epithelium. If you do a lavage on this mouse, which I've done, it's bloody, it's thick, it's turbid, it's pretty disturbing. We took these to a histologist, and we blinded the histologist to treatment and showed that there were objective markers of injury in both male and female mice at 6 and 24 hours of exposure. At P14, we're actually able to put a catheter into the trachea of these mice and measure their pulmonary function. And so here I've combined male and female mice. There was no difference between the two. And we looked at resistance. So consistent with a bunch of debris in the airway, we see an increase in resistance in acetaminofén exposed mice. And this is at 6 hours of exposure. We see an increase in elastance, inverse of compliance, with exposure to acetaminofén, but absolutely no difference in lung volume. So we thought that we concluded that these findings were consistent with what we were seeing on histology. And then we started looking at the transcriptional response. So we looked at NRF2 targets. So NRF2 is a transcription factor that responds to oxidative stress. We looked at target genes downstream of this protective response element. Two genes that we use as indicative of activation are GCLC and heme oxygenase 1. Those are significantly elevated after exposure in male and female mice. So we think this is consistent with an acute oxidative stress. We looked at cytokines, including IL-6 and IL-1 beta. Those are both significantly elevated in male and female mice. And then consistent with IL-6 signaling, we see activation of STAT3 in male and female mice at 6 hours of exposure. And those graphs are nice, but I think that these pictures really hit home. So we did RNA scope again, trying to figure out what cells are expressing IL-6. And so this is the control lung at P14. You see CYP2E1 scattered throughout the mesenchyme. This is at 6 hours of exposure. So you can see CYP2E1 expression has gone up, and we have reasons to believe that is happening that I can talk about at the end. And then you see this intense red IL-6 staining around the airways, in the airways that are demonstrating injury with the cells sloughing off and dying. Okay, so then we did tunnel staining. So essentially this is looking for cells that are undergoing apoptosis by labeling the loose ends of DNA. At the top, we have male mice. At the bottom, we have female mice. These are saline controls. And then this is after 1 dose of acetaminofén, and you can see that significant increase in staining around those airways. The last thing we did as part of this project was allow these mice, after a single dose of P14, to grow to P28 and looked at their lungs. And then we also did pulmonary mechanics on these mice. And what you can see is we have PBS saline on the left and we have acetaminofén on the right. And in the close-up micrograph on the bottom, you can see that the alveoli are just a little bit bigger. So it's a subtle injury for sure. But when you objectively assess that using mean linear intercepts, which is essentially the length of the line as you cross alveoli. So the longer the line, the bigger the alveoli are. There's a significant increase in mean linear intercept after one dose of acetaminofén, and the septal surface area per air volume is significantly decreased. So just speaking to less surface area in this lung. And when we do mechanics on these mice at 28 days, we find that the resistance is no longer different. So we no longer have debris in the airway. But when you look at elastance or the inverse of compliance, so elastance is down, so these lungs are like really compliant, really baggy. And when you look at lung volume, so the amount of air that the lung is able to accept, that is actually significantly increased as well. So demonstrating, at least in mice, a single acetaminofén exposure has long-term implications on both pulmonary structure and function. Okay, so the summary is as follows, or my summary is, clinically, acetaminofén exposures are common during critical stages of development. This is because it is an analgesic that is commonly used during pregnancy. It is my belief that there are no available clinical data, no robust data to support the statement that acetaminofén exposures do not injure the developing human lung. Preclinically, I'm convinced that we have data that mechanistically link acetaminofén exposures to lung injury. I can demonstrate this via transcriptional response. I can show histological and morphometric changes and functional changes both acutely and long-term. And so as neonatologists, I think all of us have seen kind of this graph, and we think of, the trajectory of lung function increasing after term birth until the age of 25, and then gradually decreasing over time. We believe that our babies that are born premature and in a state of immaturity, exposed to oxygen, mechanical ventilation infections, start lower, have a different trajectory to maturity, and then potentially even decrease with their function sooner. And so I kind of wonder, with the associations that we have with prenatal exposures and poor childhood respiratory outcomes, and the exposures that we're invoking now in the neonatal intensive care unit, if it would make sense to potentially add acetaminofén to this list of insults. So with that, I have to thank all the folks that have worked on this. I'm not a toxicologist. I do think about lung injury. I do think about innate immune signaling. But David Orlicki is a pathologist at the University of Colorado who's been helping me. Evgenia helps me with all the RNA scope. Brad Smith is an incredibly talented biomedical engineer who helps us ventilate and assess lung function in the mice. And then this is a clinical project. So David and Eric have been key in, helping me think about these questions that we're interrogating at the bench with clinical data. So I think with that, I will stop and open it up for questions.
All right, Clyde, thank you so much. This was a great overview, the starting off with the pharmacokinetics and the pharmacodynamics of how APAP, I like that sort of abbreviation, works, how it can be toxic or not, depending on your age and your development of certain systems. And then you took us to what I find is really important, that clinical work, just looking for associations, looking for further questions to ask, where you put up two things, which I bet some questions will come up, and I will have some questions about that too. It crosses the placenta. So what is it with that? And then, of course, how difficult it can be to interpret outcomes if you have a PDA versus paracetamol, because those are the babies who receive it. And then you took us one step further on all this animal data and showed us what it does in particularly one significant toxic dose. And I guess we are waiting for also, what about if we give the normal dose, what it would do then? And I bet you're working on that as well. Yeah, we have some time for questions. There's nothing in the chat box yet. Victor did say that he works in Singapore, that actually a lot of Asian countries are using IV paracetamol as first-line treatment in the PDA. I will start off with a question. So you mentioned that paracetamol passes the placenta and that there is associations with pulmonary outcomes, but particularly that can be quite tricky. But is that dose dependent? Do we have data on dose dependent sort of?
Yeah, so that is really hard, and I wish that we did, because you can imagine a lot of these databases are asking moms, how much Tylenol did you take? When did you take it? So people have tried to look at, there's very little based on dose, but there is some based on trimester. And it seems that ingestions in the second and third trimester might have the strongest association with poor childhood respiratory outcomes. And, I would like to think, the last thing I want to do is be up here and try to advocate for taking away the only like safe analgesic that you can take during pregnancy. But I would like to understand, maybe there is a window, because it does freely cross the placenta. And, some of our work that I didn't present here is looking at giving the dam a dose, an analgesic murine dose, and looking at the developing lung. But maybe there is a developmental window or precise window where these cells are expressing CYP2E1, and you say, like maybe in this window you don't want to take CYP2E1, or maybe it's as simple as taking, or you don't want to take acetaminophen, or maybe you want to take acetaminophen with a little glutathione, or something to make it a little bit safer. But I think if we understand the biology a little bit more, we can make the drug safer.
Yeah, that's a really good point, isn't it? Not only the biology, which is clearly your field, but also the physiology sort of behind it, which brings me sort of to my second question. The PDA is giving volume overloads to the lungs, and that particular sort of shear stress and abnormalities can create its own set of findings in the lungs which are abnormal. I know clinically we call it BPD. I think it's one of the worst definitions we have. It's just so unhelpful. But is there any data which you can say, wait a minute, this is the trauma you get from acetaminophen, and this is the trauma in the lung which you get from volume overload in animal? I'm assuming animal data.
No, because we just published that P14 data I showed just actually last week. And I think we're the only ones that are exposing animals at these specific developmental stages. Mm-hmm. And I think it's, to me, it's interesting that we can get these subtle findings of abnormal lung development with this single dose. But the big question is, most of the babies we're exposing to acetaminophen are not healthy. They're on supplemental oxygen. They have poor nutrition. They have low glutathione stores. They have pulmonary overcirculation. So, adding a second hit to see if we can exacerbate this injury, teasing them apart is going to be difficult, but can you add insult to injury by causing an additional oxidative stress that the cell cannot recover from? Because if you took Tylenol tonight, your liver, you'll have glucuronidation, sulfation, and then as a last resort, CYP2E1. These lung cells, if you look for expression of sulfating enzymes, glucuronidation, they're not there. So if this cell sees acetaminophen, there's only one thing it can do with it, and that's create the toxic metabolite. And hopefully it has enough glutathione. If it doesn't, it's dead.
Yeah, I was also curious about this is, of course, it's it's not a new medication, but it's been used much more in our very fragile babies. But been using, other medication, furosemide, even blood products. Do we have information about that in a similar sort of context?
Yeah, with CYP2E1, or just how it might affect the developing organism?
Yes.
No, and I think these are questions like, as we have these funded studies, we have them in the lung, in the kidney, and we're understanding like, yes, there is a developmental expression profile of these enzymes and understanding there might be specific windows where, we extrapolate what we know about adults and how these drugs might be toxic, but we're talking about a totally different developmental stage and a totally different set of cells. I think it opens up a whole new world of research in which hopefully we can make the use of these medications safer.
Yeah, yeah.
Can I just say one thing? So about that dose we used, because I get that a
Yes.
lot, and I'm just this is what I'm gonna say. So like over here on the right with human dosing, so you can kill an adult, 50% of adults by giving them 160 to 200 per kilo. The FDA daily max is 4 milligrams. And for PDA, we're using about 60 milligrams per kilo, which is about the FDA daily max. But humans are not the same as mice. And so if we look at mice data, an analgesic dose of acetaminofén in a mouse is 200 milligrams per kilo. So that's less than we're using. And you don't get toxic or death in adults until 600 milligrams per kilo. And when you do the reason we did 140 milligrams per kilo, when you do this allometry looking at surface area, weight, and metabolism, you're supposed to divide a murine dose by 6.3 to get an equivalent human dose. So I think the dose we're giving is equivalent to about 120 milligram per kilogram dose, which is kind of scary.
Yes. All right. Victor, you want to ask a question to Clyde? Just unmute yourself. Sam.
I will unmute. Yeah. I am Sam from Singapore. Clive, great talk. In Southeast Asia, the regional countries I have visited, including Singapore, we can't ignore PDA. We see massive pulmonary hemorrhage time and again as a complication. And in about 30% of the cases, they are associated with severe IVH in babies below 28 weeks. And acetaminophen is used. We also see, increase in lung injury resulting in BPD and BPD-associated pulmonary hypertension. My question is there any brain injury as well due to paracetamol during this vulnerable period? Non-randomized studies have reported for and against. Some say no problem, they're okay. Comparable results, retrospective cohorts treated with COX inhibitors. Some say increased incidence of autistic spectral disorder in this group of infants. Appreciate your comment. Yeah.
Yep. And, I don't know if you guys were aware, but in the United States, there was a large class action lawsuit looking at the association between prenatal acetaminophen intake and the development of autism spectrum disorder. Did that make its way to Australia? So it was massive. The courts threw it out, but a bunch of moms got together and sued like CVS, Walmart, all the places that sell these medications. And the mechanism they were purporting was disruption of the cannabinoid system. I think that the data supporting that are relatively weak. However, the microglia, and we know that those are really important for brain development, do express CYP2E1, and it appears that that might also be developmentally regulated. So you could definitely hypothesize, in a baby that is already at risk and you give a dose of acetaminophen and you kill, 10, 15, 20% of these microglial cells, could you have a subtle signal for abnormal development? I mean, until we're following these outcomes and appropriately powering our studies to look at them, we'll have no idea. And so, your message resonates with me. We have these smaller babies, in my institution, the 22, 23-week babies who have PDA, they're getting acetaminophen because a lot of them are on hydrocortisone and we're nervous to give them NSAIDs because of the risk of spontaneous intestinal perforation. You know, the use of acetaminophen is not going to stop overnight, but there might be a way to give it safer, and I think we should be following their outcomes. And I think brain outcomes, another place that CYP2A1 is expressed is the kidney. We should be following their renal outcomes as well. Just because the liver isn't injured, this is not a safe drug. I think that's what my message should be.
Yeah, I really like that. I think it's a really important one to relate to. That is not the main measurement to look for. However, in a lot of these, exceptionally vulnerable patients, we give so many different kind of treatments and ideas that it's sort of impossible to withhold all these things, because whether it's chemical or plant-based, there will also be doses which will do something pharmacodynamically and pharmacokinetically in those little bodies. Clyde, I think we're at the end. There's one more question from Charles Kilburn. Is it likely there is a safe developmental window for APAP then? What would be your current guess?
Yeah, I would think so. And the thing I'll leave you with is, we think we put CYP2A1 into this xenobiotic bucket, like it metabolizes things from outside the body. But it's my belief that's not why it's there. It is actually a metabolic enzyme. So if you starve yourself tonight, your hepatic CYP2A1 expression goes through the roof, and that's because it can metabolize ketones to gluconeogenic precursors. So why would it be that the lung would make CYP2A1 at these specific stages? My guess is in a mouse right before birth, you're probably mobilizing ketones to glycogen to prepare for surfactant. So we're working on that process. And when you have the secondary alveolar bloom, I think that's probably an energy-dependent process. And CYP2A1 is just a way to access alternative fuels. So yes, I think there probably are developmental windows where you'd want to stay away from it, and probably developmental windows where it's exceptionally safe. But the more we understand the biology, hopefully we can define those things and make the use of these drugs safer.
Not there yet. Wait
yet.
for this. Wait for further publications.
That's
All right.
right.
I want to thank everybody. Clyde, thanks so much for presenting first. Thanks everybody for attending. Next week we're back. We have Pranav from Sydney talk about humidity next week. Thanks everybody. Thanks for attending. Thanks, Clyde.
Yeah. Thank you so much.
Thank you.